Hi all, it's Charlotte Appleton with Cesare Project. Today's question is, why is it that whenever we dive into disease, it blows up into insane complexity? In this video, I take a look at a Science Alert article that explores dementia, and we find that this complexity blowing up in our faces situation is alive and well. Dementia is a real problem today. It's not well understood, is devastating to patients and their families, and is very expensive to care for. Whether family members have to quit their jobs to take care of a loved one with dementia or struggle with the finances of putting them in a nursing home, for example, it's a very difficult disease both emotionally and economically. Unfortunately, we can't get past the confusion of what it is or what to do about it. In this video, I review a Science Alert article entitled "Scientists Name New Type of Memory Loss Often Mistaken for Alzheimer's." Though my question is, does it actually represent a different disease? Simply giving something a new name based on a series of symptoms or pathologic findings doesn't necessarily make that meaningful or useful. Despite that, it can create a whole bunch of new questions that don't answer the question that it was trying to answer, which is, what is dementia? As I look at this article, I'm trying to understand what the goal of this research is. Is it to find the cause? Is giving something a new category or name helpful? Let's check it out. Here's the Science Alert article published 30 July 2024, and it starts with the comment that a little-known form of dementia, easily mistaken for Alzheimer's disease, now has a brand new name and specific diagnostic criteria. Researchers are calling it limbic predominant amnestic neurodegenerative syndrome, or LANS for short, thank goodness. And they hope that their work makes it easier for medical professionals to care for and counsel patients with various forms of memory loss. Already from a clinical standpoint, I have a lot of questions here. Dementia is diagnosed when a patient presents with memory loss that goes along with some other form of cognitive decline, such as an impairment in language, motor function, or thinking ability like problem solving. When it comes to treatments, all we have are a handful of drugs that help alleviate the symptoms of memory loss or the behavioral issues that go with it, but nothing really slows it down or reverses the process. So my first question is, does subcategorizing or creating a new category of dementia create avenues for different solutions? As of today, no, we still only have the same handful of medications and advice to offer families and patients on what to expect. In terms of making it easier for medical professionals, it actually makes it harder. When you have yet another diagnosis to consider or another billing code, it just adds to the heap of other diagnoses without really changing the management. Let's see what else is here. LANS presents with a different set of brain changes compared to Alzheimer's and tends to progress slower and with milder symptoms, mostly impacting those over the age of 80. So when it comes to dementia, this is today's version of good news. If you have an irreversible disease that we really can't do anything about, well, having one that has a little slower progression and milder symptoms is preferable over a rapidly accelerating syndrome. I think that's a very low bar, but unfortunately we have to take what we can get today. Similar to Alzheimer's, definitive diagnosis is only available at autopsy. So obviously that doesn't help the patient, but research uses that information to try to improve the lives of others. This article goes on to report the reason why it's important to distinguish Alzheimer's from LANS, and that really comes down to, I think, expectation management. If you can tell a patient and their families, well, yes, you have this irreversible condition, the one good thing is that it's a bit slower. In this research report, patients with these two types of dementia are differentiated based on brain imaging and biomarkers, which are blood tests or fluid samples that contain certain types of markers that in some way indicate severity or progression of a disease. Clinically, there's none available for dementia, though there's a big research interest in establishing that. Again, that only helps with diagnosis and expectation management today, but that presumably will lead to new treatments that will be monitored for efficacy based on trending these biomarkers. As the researchers tried to separate out patients who died of LANS from those who were labeled as Alzheimer's patients, they found that there was a lot of overlap. And that's not unexpected when we're dealing with clinical syndromes. They focus on the specific type of brain changes they found, and that these changes were found in 40% of autopsied brains beyond the age of 85. So that means that the changes can happen in the absence of dementia. That's a confounding factor. What does it mean? Nobody knows. However, they hammer the point here that the two diseases are distinct. And I'm still asking the question, well, why does it matter? Now, instead of having one disease we can't explain, we have two. the complexity is rising. In the search for understanding, we meet rising complexity and uncertainty. Let's take a look at the original publication. The title is Clinical Criteria for Limbic Predominant Amnestic Neurodegenerative Syndrome, published 17 July 2024 in Brain Communications. This has an impressive list of authors. I combed through them and they represent neurology, neuroscience, laboratory medicine and pathology, psychiatry and psychology, an Alzheimer's center that centers around the Mayo Clinic. In the abstract, the authors indicate why it's important to separate these two types of dementia. They comment that they may differ in underlying etiology or cause, and that they can have different clinical courses which can improve counseling and expectation management and can make a difference in therapeutic needs that have yet to be discovered. So again, while not insignificant, it has created more uncertainty that now demands answering even more questions than what we started with. Here they expand on this idea of clinical criteria that point to LANS. Clinical criteria are really common, and doctors and providers in all the healing arts use them to define a condition based on the set of symptoms that are present. Let's take a look at these criteria. So first are the core clinical features. Must present with a slow amnestic or memory loss, predominant neurodegenerative syndrome, insidious onset with gradual progression over 2 or more years, without another condition that better accounts for clinical deficits. So that's a word problem in and of itself. So their definition of slow is the progression of symptoms over 2 or more years, which can be seen in lots of types of dementia, that they have memory loss, which is a defining feature of dementia, and that you've ruled out other potential causes of this syndrome, for example, recurrent strokes or Parkinson's disease, though that doesn't necessarily separate it very well from other types of dementia. So some standard supportive features include older age, generally 75 and older, so that's kind of hazy, mild clinical syndrome, atrophy of a certain part of the brain seen on imaging that appears out of proportion to the syndrome's severity, which is a subjective call. And impaired semantic memory, which is the ability to recall words and numbers, things like that, in the setting of a mild syndrome. So it's a very particular kind of memory loss. It goes on to describe different imaging findings and establishing degree of certainty. Medicine thinks it's dealing with degrees of certainty when actually we're dealing with uncertainty, which is not measurable. This sounds like a subtle point, but it's a really big problem. Certainty isn't the opposite of uncertainty, and that's a very confounding issue in medicine today that is beyond the scope of today's discussion. The point here is that these criteria were designed to help determine is LANS likely or not in a particular patient's case. And that's the best we can do in medicine, is determine, well, what do we think we're dealing with here? Could it be A or is it not A? That's uncertainty, not certainty. This goes into neuropathologic assessment, imaging, biomarkers, which are all experimental right now, optimizing these criteria, which, given how complicated this list looks, needs a lot of work. Statistical analysis. This is where we can really tap into the complexity of the situation. And here's that complexity in a typical biomedical research study where there's charts and graphs and all of these complicated concepts, some imaging of the brain, all these acronyms that have to be defined and redefined, likelihood differences. And so we're really trying to make sense of the complexity. We're trying to find the threads of disease reality despite this very kaleidoscopic view of disease that we commonly get. How do you find the patterns that matter amid this wild complexity? It keeps going. Binary classification, that means trying to put patients into one of two groups when a lot of them don't neatly fit into either of those groups. Heterogeneity means there's a lot of variability. Here's the discussion. And we find that this is a very long article. So when we consider the title that was focused on creating clinical criteria for this new type of dementia, it required pages and pages of complexity just to create the clinical criteria that in the summary article boiled down to a new name or category of dementia that we can't explain, reverse, cure, or prevent. Does that make it meaningless or useless? No, it just makes it very confusing and deals with being in a rabbit hole by digging the rabbit hole deeper. We've completely lost our orientation to what matters here, which is understanding dementia. We've got to step back and say, the data is not the problem, but how we think about the data is. What are we missing? We don't have the framework to make sense of what we're seeing. But for the most part, we get the sense that these researchers are trying to understand dementia and improve the situation of this very complicated and poorly understood disease. However, without a fresh framework that makes sense of this, it's only going to add to the confusion and not bring the answers and healing that everyone craves. The take-home point here is that the goal is not to cure dementia. They weren't looking for the cause of dementia. Instead, these researchers, as is common in research today, get lost in the complexity of trying to understand diseases and find that the deeper we dive, the more uncertain everything is and the less we seem to know. That's how it is with adaptive systems. Adaptive systems evolve and change and respond. Humans, their organs, and their cells are no exception. This idea that we can look at humans' organs and cells and find mechanistic processes that lead to disease in a cause and effect relationship is inadequate for understanding or dealing with problems of this nature. So how do we develop a framework that makes sense of the complexity in a more simplified way? Do you have any ideas how to do that? I'm honestly curious because it's something that I'm working on. How do we think differently to make sense of this kind of information? Thanks for listening. Have a great day.